From the JAMA Network, this is the JAMA Pediatrics Editor's Summary, a discussion of the most important articles published in the latest issue of JAMA Pediatrics.
Hello again, podcast listeners. This is Dimitri, Christakis, Editor-in-Chief of JAMA Pediatrics. With me, as always, my friend, colleague, Associate Editor, and soon-to-be Division Head of Health Services at Boston Medical Center, but at least at the time of this recording, still at Harvard, is the famous Alison Galbraith. Ali, how are you doing?
Hi, good. Nice to be here.
Nice to have you, and congratulations again on your new job. We're all very excited about it. We have two papers, Ali. You want to go first as usual?
Yeah, so the paper I have is called Association of Youth Suicides in County Level Mental Health Professional Shortage Areas in the U.S. It's a cross-sectional study from Hoffman and colleagues, and it looks at the association between county level mental health professional shortage areas and child and adolescent suicide rates. So, suicide is the second leading cause of death in adolescents, and it's rising. And right now, there's shortages of mental health professionals, and this is especially true in rural and high poverty areas. So a lot of kids who need mental health care can't get it. So that motivated this study. They used national data from HRSA, from the Health Resources and Services Administration. And HRSA designates counties as health professional shortage areas. And they do this for primary care, and they do it for mental health as well. And then they use that to determine eligibility for different federal and state incentive programs, like the National Health Service Corps and things like that, and reimbursement rates and things like that. So this study used those health professional shortage areas for mental health. And the way that HRSA categorizes that is they look at the number of mental health professionals, including psychiatrists, but also other mental health professionals, relative to the overall population, as well as the area level need for mental health services and the availability of services in contiguous areas. The authors use it as a binary, yes or no, you're a mental health shortage area. And then if you are a mental health shortage area, they score you between 0 and 25, with higher indicating a greater workforce shortage. And then they got suicide data for children aged 5 to 19 from the CDC, from the death certificate files, and then used population estimates to do rates per population. They did modeling. They adjusted for a bunch of different county level socioeconomic factors and whether there's a children's mental health short-term hospital in the area.
So I understand, and our listeners do, is to see whether or not having more mental health services available or not having them available is associated with an increased risk of suicide. Is that right?
Correct. With the idea being that, you can't get the treatment that you need for a mental health condition and it might end up resulting in suicide. Yes, correct. And then they also looked at it just separately for firearm suicides, because I guess there's data that show that they didn't think there would be an association if it was a firearm suicide, because there's another study that didn't find that in young adults, and also because there's some other data that those are less likely to be preceded by a known mental health diagnosis. So they didn't think there would be an association. And as we'll see, there was. So what they found was that, first of all, there's a lot of, unacceptably high, more than 5,000 suicides during this time period, which was 2015 to 2016. The annual suicide rate was 3.99 per 100,000 children. 73% were male. And more than 2/3 of U.S. counties were designated as mental health workforce shortage areas. They have a map in the paper, and the maps are really striking. These areas, what are shortage areas, tend to be, they look like they would be rural. They're kind of in the Southwest, and they're in the West, kind of mountainous regions. But their main finding was that they did find that there was an association between mental health workforce shortage designation and increased youth suicide rates. So there was a 1.16 incidence rate ratio for having a mental health workforce shortage designation. They also found there was a significant increased incidence rate ratio for firearm suicides as well, which, as I said before, they were not expecting. And then this is like a smaller point, but they looked within the areas designated as workforce shortage areas and looked at their sort of score that I mentioned before. And the higher score you got, the worse your shortage was, the suicide rate increased 4% for every 1 point.
So there's like a dose-response relationship, which would further suggest causal association.
Exactly. Yeah. So, one thing, I guess, thinking of implications of this is, I can't imagine this isn't worse now during COVID, and we're really seeing greater mental health need and bed shortages and, wait lists for kids to get seen, and So I think that'll be important to see how this plays out going forward. I guess the other question is, what do we do about it?
Well, I guess there are two things, right? So the first thing you said, shortage areas. I mean, what's interesting is I didn't know there was such a thing as a non-shortage area. I mean, it's very hard to get mental health services in Seattle. I imagine it is in Boston too. I don't know what constitutes
Yep.
non-shortage, but it does make me think that shortage must be really remarkable because we have week-long wait lists here already.
Right. Well, so that's the other thing. You might have the numbers. You might have a number of mental health professionals, but if you can't get in to see them or there are other barriers, then it's necessary but not sufficient, I suppose.
So yeah, what do you think the implications, or what do you think what did the authors say are the implications for this in terms of solving the mental health crisis, which is, as you said?
Yeah, they talked about that. And also there was a nice editorial from Aaron Carroll and a colleague of his that talked about, there can be more done to do more workforce development programs to try to increase the pipeline of mental health service professionals. That will take a while. And I think for that to happen, there needs to be better reimbursement for those folks. There's other things, I guess, in the meantime, better integration of mental health care into primary care or telehealth. I guess that's the thing, that wasn't around during the time of this study. And is there a way to extend across these areas, telehealth professionals in a different county be able to help people in a county that doesn't have mental health professionals? So
I think telehealth has to be part of the solution, don't you think? Because I mean, historically, the problem has been that for a lot of reasons, some people don't want to live in rural communities, or there isn't the perception there's enough business there to make it worth their while.
right. And that will need policy solutions too, to make sure that there's still reimbursement for telehealth that will.
And across state lines. Yeah, it's interesting. I don't know why. I mean, I suppose there are good historical reasons why these barriers exist to providing care across state lines. But hopefully, if there's, part of the upside of the COVID epidemic will be that these things go away and stay away. But I don't know.
Well, right. We know we could do it, right? It happened in COVID. We were able to have telehealth across state lines and do some of these things.
Right.
It's possible.
Thanks. And the next paper we have is the effect of virtual reality environment using a domed ceiling on procedural pain during IV placement in young children. It's a randomized controlled trial out of South Korea. And we all know that procedural pain or even pre-procedural anxiety for young children is a problem. And technology here has potential to have some promise. We have a lot of papers talking about the downside of technology in kids. And I think virtual reality may, in fact, be a good short-term solution to pre-procedural pain and anxiety. We've published some papers before using virtual reality in kids and procedural pain. And the challenges with the papers we've published before, and a lot of the literature has been that children have to wear these VR glasses, which can be A, cumbersome, B, poorly fitting for young children in particular, and C, intolerable for children with certain conditions. So they wanted to test whether having a kind of virtual reality domed ceiling would work so the kids wouldn't have to wear the glasses. And the interesting thing is they opened the study to children 6 months to 4 years, which I thought was fascinating because, for one thing, obviously for very young children, if it worked, it would be great but I was skeptical that it would work for kids that young, just knowing what I know about young children and video viewing. And they randomized them to either normal IV placement or having it placed in this theater room. And they videotaped the kids. They did a good job of blinding it. And they asked providers to grade them on the FLAC scale. We use that clinically in our hospital. I don't know if other people are familiar with it, but it stands for face, legs, activity, cry, and consolability. And it's a visual scale scored by an observer to assess distress and pain in young children. So they had 2 physicians blinded to study protocol do that at 4 time points: before, during, and after the procedure in both groups. And a couple things of note before I get to the results. The kids that they enrolled, the average age was 24 months, and the interquartile range was 14 to 44 months. So they didn't really have very many very young children, which I think is important because obviously they weren't really powered then to see whether or not it worked for very young children, as I suspect it would not. And what they found actually was that there was an overall effect, that the VR group had significantly less pain and distress measured by FLAC score with an odds ratio of 0.53. And then when they did a subgroup analysis looking at boys separately from girls, they actually found that it worked for girls and apparently not so much for boys. Now, that itself, I think, is worth commenting on, and they commented on it themselves. I'll tell you what they said, but I have my own sort of thoughts on this. I didn't tell you that the video they used was a virtual reality of 4 animals. What were they? Bears.
There was like 4 different they were animals. They were like, and the kid was as if he or she was running around with the animals.
And during while they were having their IV placed. So the short answer is, does this domed virtual reality work? Overall, it appears that it does, with a significant reduction in pain, with minimal cost, minimal inconvenience, and clearly no discernible or theoretical downside risks to participants. They comment that the reason this might have worked for girls and not for boys was that there are expectations that boys be quote unquote braver, which I thought was interesting. Now, I don't, these are very young children. These are 2 to 4-year-olds. The average age was 2. And that they claim conditioned to have a higher pain tolerance than girls are in Korea. I'll let you comment on that, Allie. I would not have had that hypothesis for kids that young.
Yeah, that would not be my hypothesis.
And it may have, which they did comment, it may have had something to do with the virtual reality. I don't know, and their sample size was pretty small. So who knows if there really is a gender difference, but they did do that exploratory analysis. So what to make of this? Well, I think it's an interesting study. I think it does show some promise of a technology. It does require, I suppose, some retrofitting of a room to do this in. They didn't explain, they did, but I don't know from a technical standpoint how difficult or expensive this would be to do.
Yeah, that part wasn't clear to me, how you would create this, how easy it would be to set your ceiling up. They projected onto the ceiling, so I don't think you had to have technology in your ceiling, but I think you had to have it be domed to create this immersive experience.
Right, but I don't know what doming your ceiling means. I don't know if they're talking about
I don't know.
Sistine Chapel or just putting up that wasn't clear. So I don't know, but it's certainly something that I think warrants further consideration, not to be confused with having children do virtual reality all the time. I think this would be an exception during a procedure, and presumably, potentially, could come in lieu of pharmacological anxiolytics, et cetera, which clearly have their own risks.
Yeah, one thing I thought was interesting is they did the FLAC scores a couple different time points leading up to actually putting the needle into the kid's arm. And it improved the FLAC scores, made kids less anxious or whatever ahead of time too, which I thought was really interesting. Because there's a certain, I can think of this like from my own kids, right? That like the lead up is really stressful because your kid is stressed about what's about to come. And so it helps your overall experience by distracting the kid in the lead up to it too. So I think there's some value to that probably.
I agree. And again, the age range they intended to enroll, which is way broader than the age range they actually did enroll, is a pretty broad, right, developmental window. You don't think of 6-month-olds as having anticipatory anxiety about an IV that's going to be placed because they don't have any clue, I think, what's about to happen.
Right. Do they really need it, right? They don't know what's about to happen.
Right. But a 4-year-old at the other extreme clearly does, and a 2-year-old is somewhere in between. So I think the other point would be for future studies to have more narrow age bands to see, because I suspect there's effect modification by age, and more so even than gender, and also, neurodevelopmental status.
The one other question that I had was the degree to which it made it harder for the person placing the IV. It would be easier for them, right, if the kid is not stressed and thrashing around, but is it distracting to the person trying to put in the IV if the kid isn't paying attention? I don't know. The parents thought it was good, but they didn't ask not the provider. It was like an EMT or somebody who put it in, I think.
Right. The parents thought it was good, but of course they weren't blinded to the intervention status, and having been randomized, they may have thought that this was a great idea to have their child in front of the screen. Okay, well, thank you very much once again for spending some time with us. We will see you again next month. You can find this and other podcasts at jamapediatrics.org. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.